who is a palliative physician, and she did her certificate course in pain and palliative medicine from Pallium India, and she has recently finished her fellowship in pain and palliative medicine from Pallium India, and she has around 10 years of experience in palliative care. Now she is heading the clinical services of for clinical service department of Pallium India. So she is a well-versed person in this field. Ma'am, welcome and over to you.
Thank you, Ambadi and Shiva, for that kind introduction. Good afternoon, all. So, as Shiva and Ambadi has already mentioned, today we will be discussing on the management of pain. I hope the management of pain of step 1 and step 2 ladder was done in the previous sessions. So today we'll be dealing with the opioids. So what all will be discussed in today's session includes the commonly used opioids, the mechanism of action of opioids, the practical aspects of opioid use, the adverse effects of opioids, and the prices of different opioids. So I would like to brush you through the WHO analgesic ladder for cancer pain management. I hope you all remember the WHO analgesic ladder, which says that patients with mild pain are prescribed with step 1 of the ladder, which includes non-opioids plus or minus adjuvants. And if the pain continues, then we escalate to step 2, which includes opioids for mild to moderate pain, plus or minus non-opioids, plus or minus adjuvants. And when we say opioids for mild to moderate pain, that is the step 2 opioids include tramadol, tapentadol, codeine. All this, I think that has already been dealt. And if the pain is more severe, then we move on to step 3 of the WHO analgesic ladder for pain management. And this includes opioids for moderate to severe pain, plus or minus non-opioids, plus or minus adjuvants. And today we'll be dealing with the opioids for moderate to severe pain. To begin with, we have a patient scenario where we have a patient with 56 years of age who is presented to us with carcinoma of larynx. He is presented with pain around the neck, which has a severity of 10/10, which is a sharp pain with no radiation. Since the last 2 weeks, he is having this pain and is unable to sleep because of the pain. So, how will you manage this? How will you manage this pain? So I would like this session to be an interactive one so that the learning becomes easier. So I would like the responses either in the chat box or you can unmute and speak. So we have a patient. Oh, am I audible? Can someone confirm? Am I audible?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you, Dr. Pinky, for that. So, okay. So we have a 56-year-old man who was diagnosed with carcinoma of larynx with a severe pain of 10/10. It's a sharp pain with no radiation. And since last 2 weeks, sorry?
Ma'am, if possible, we can manage with tramadol. If not possible, we can give some sedative. Is it?
Okay. Thank you. Thank you for that response. Do we have any more responses? So, I think we have already learned about the WHO analgesic ladder for pain management. And which step of the ladder does this patient belong to? Can someone unmute and answer? So the patient is having...
Morphine, opioids, ma'am. Morphine.
So that is step 3 of the ladder, which includes opioids for moderate to severe pain, plus or minus non-opioids plus or minus adjuvants. Why do we go for step 3? Because the patient has presented with severe pain, 10 on 10
10 by
pain.
10 sharp pain, ma'am.
Yes, and it is a sharp pain with no radiation, which indicates that it is a nociceptive pain. And opioids could be the best choice. So how do we move about with it? So if we have decided on the drug, what next? Suppose such a patient comes to our inpatient unit or our OPD, how do we manage it? So this patient needs immediate pain relief. So what we do is, next, the procedure is intravenous. So we go with intravenous morphine titration. So what anybody is, are you all, anyone is familiar with intravenous morphine titration?
No, ma'am.
No, ma'am.
Okay, so intravenous morphine titration. So what we do is that 1 ampule of morphine contains 1 ml, and that 1 ml contains 15 milligram of morphine sulfate. So this 1 ml is being diluted with 9 ml of distilled water and made of 10 ml of diluent. So that 1 ml of the diluent solution contains 1.5 milligram of IV morphine, injection morphine. So I'm repeating, 1 ml of this diluent contains 1.5 milligram of morphine injection. How is that? Because 1 ml of morphine, 1 ampule is 1 ml, and the 1 ml of morphine contains 15 milligram of morphine. And we have titrated or diluted it with 9 ml of distilled water, and now the diluted solution contains 1 ml contains 1.5 milligram of morphine. And so with this diluent solution, we are going to do the morphine titration. The first step that is involved in morphine titration is that we start the titration with, initially we give injection metoclopramide. So injection metoclopramide 10 milligram intravenously is given to the patient. And that is once after the injection metoclopramide is given, we start with the IV morphine titration. So before we start with the IV morphine titration, what all needs to be recorded? We need to check the vitals of the patient, including
BP, pulse, respiration.
yes.
Oxygen saturation, ma'am.
Saturation.
So this is how we do the IV morphine titration. So before we start with the titration, what we do is we record the vitals. That is the pulse, the respiratory rate, and of BP is recorded. Along with that, the most important is recording the pain score. So to continue with the titration, what we need is so we have given injection metoclopramide 10 milligram. Then we have started with the injection morphine. 1.5 milligram of injection morphine is given. And before we give 1.5 milligram of injection morphine, we check the respiratory rate. Then we also check the pain score of the patient. So what was the pain score of the patient? That was 10 on 10. And this 1.5 milligram is given at 10 minutes interval. And this titration is continued, or the endpoint of this titration would be when the patient has satisfactory pain relief or the patient feels drowsy. Whichever is the first indicator, we stop the titration there. So that is IV morphine. So suppose a patient is started on IV morphine titration at 10 a.m. We recorded the pain score as 10 on 10. The patient was not drowsy and 1.5 milligram of IV morphine was given. So after 10 minutes, that is at 10 a.m., we will record the pain score again. So the pain score was 7/10, the patient was still not drowsy. So he was again given 1.5 milligram of IV morphine. Again, wait for another 10 minutes, then reassess the pain score and then see the drowsiness. If the patient is still not drowsy and the pain score has come down to 4 in this scenario, so again, we provide the patient with 1.5 milligram of IV morphine. Now wait for another 10 minutes. By 10:30, reassess the pain score. Now the pain score has come down to 1. So what do we do now?
Stop the morphine IV.
Yes, exactly. We are stopping the morphine titration. This is because the pain score has come down. The other indicator would be the drowsiness. Whichever occurs first, that would be the endpoint of the titration. So now we have stopped the titration, and currently, what is the dose of morphine that the patient has been given? Can somebody unmute and talk? So we have given 3 doses of 1.5 milligram of morphine. That is 4.5 milligram of morphine is being given to this patient. Suppose this patient wants to go home. What do we do?
मैम
Any
ओरल पे
suggestion?
डाल देंगे, ओरल पे दे देंगे, डाल देंगे उसको.
हाँ, but how?
वो नहीं
Very
मालूम है.
good. Very good. So we have to send the patient home, and the option would be to send it orally. And for this, what we do is to convert this IV morphine to oral morphine. We do 1:1 type conversion ratio. So the patient was on 4.5 milligram of IV morphine and had good pain relief. Now we want to send the patient home. The best choice would be 4.5 of oral morphine, or the nearest, round it off to the nearest available dose of tablet, that is 5 milligram. So now we'll send this patient home on 5 milligram of oral morphine.
मैम एक क्वेश्चन था मेरा.
Yeah, please.
मैम जैसे ये 3 डोज में आए, तो अगर ये 2 डोज में आता तो जितनी डोज बनती उतनी ही ओरल पे डालते हम.
Very correct. So what is the endpoint of the dose? How do we titrate?
वो मैम पेन के हिसाब से आपने बोला भाई, जैसे
हाँ.
1.5 और 1.5 है तो 3 हो जाती, तो 3 फिर हम 3 mg पे डालते इसको ओरल में.
Yes, 3 mg पे डालते. Let's, but we don't have. I'm sorry, my Hindi is so bad. So I do understand, but I am not confident in conversing back in Hindi. So suppose a patient got relief in 3 milligram. What would be the ideal dose is that you can either send the patient home in 2.5 milligram of oral morphine, or you can titrate to 5 milligram. So to the closest dose that is possible. Hope I made it clear.
यस मैम.
Okay, thank you. So now we are sending the patient on 5 milligram of oral morphine home. So how do we prescribe this?
Excuse me, ma'am.
Yes, Dr. Manisha.
Ma'am, what would be the duration to give this oral morphine?
Sorry?
What would be the duration to give this oral morphine?
Yes. Yeah, we are coming into that. Okay.
Yeah,
So that,
sure.
sure. Yeah. So that is, so we are sending the patient on 5 milligram of oral morphine. 5 milligram every 4 hourly is the usual prescription, or the duration at which the dose, the morphine is given. So the patient will be prescribed 5 milligram 4 hourly. So the prescription would look like the 5 milligram. First dose will be when the patient wakes up or at 6 a.m. The second dose would be at 10 a.m. Then the third dose at 2 p.m. Next at 6 p.m. And at bedtime, we ask the patient to take 1 tablet. Why do you think we want the patient to take 1 tablet at bedtime?
मैम शायद ड्राउजीनेस वगैरह ना होता हो सोने के बाद, जैसे नींद आ जाती है.
Anybody has any other answers?
उनकी duration लंबा हो जाएगा. Duration is very long.
Yeah, so thank you for the responses. So that is because the next dosage will come at 2 a.m. We don't want our patient to wake up at 2 a.m. and take the next dose. but we want the patient to have adequate pain relief also. So in order to maintain the morphine, the amount of analgesic in the blood, we are giving double dose at night so that the patient has adequate pain relief till 6 a.m. next day. And we don't want the patient to get up at night again at 2 a.m. and take another dose. So that is why we provide the patient with double dose at night. I hope, have I made it clear?
जी मैम
Ma'am.
Yeah, okay, thank you. And we also prescribe 5 milligram as SOS dose to the patient. This is because in between, if the patient is having pain, the patient can take an additional SOS dose of morphine. So this is being prescribed along with the normal prescription. So when we prescribe morphine, tab morphine 5 milli for this patient, tab morphine 5 milligram Q4H and 10 milligram HS and 5 milligram SOS. The prescription would be like that. And I hope you all remember the principles of analgesic use. So always prescribe or follow by the principles of analgesic use. Do you remember the principles of analgesic use? Anyone? Always prescribe analgesics by the mouth, by the clock, by the ladder, and individualized treatment. So, always it is preferred to give the medications by the mouth. Oral medications are preferred by the clock. That is, as per the correct frequency, the medication has to be given. And also by the ladder that we have already learned. That depending upon the intensity of the pain, by the ladder, we provide the medication. And individualized treatment should be given to each patient depending upon their need, like symptom assessment and their symptom. So we started the patient with 5 milligram of oral morphine. So suppose the patient has come to a setting where we don't have an injection preparation. So you're seeing the patient in your home care setting and you don't have an injectable preparation with you. What do we do? And we see that the patient is having 10 on 10 pain, severe pain, and we feel that the patient might not get benefited by the step 2. And we want to start with step 3. What do we do? Anyone?
Ma'am, tablet orally we can give, tablet morphine.
Yes, yes. We can give orally, but so how do we prescribe oral morphine? So for a patient who is new to opioid, who has not already been on step 2 also, but on severe pain, we can start on step 3 with a very low dose. That is 5 milligram Q4H would be the dose with which the patient will be started on. So in a patient who has not been in step 2, that is the opioid is new to the patient, but with severe pain, and we feel that it is a nociceptive pain and could be sensitive to opioid, we can start with tab morphine 5 milligram Q4H. In a patient who is already on step 2 opioids, maybe on tramadol, then we can start on 10 milligram of oral morphine Q4H. I hope that is clear. For a patient who is new to opioid, we start with 5 milligram Q4H. And for a patient who is already on a weak opioid, we start with maybe 5 to 10. Can be somewhere between 5 to 10. Some patients we start with 7.5 Q4H or 10 milligram Q4H. So now we have another patient story. We have Mr. X. So we have already started him on 5 milligram of morphine, 4th hourly and SOS. He has relatively pain-free for the last 2 weeks. But now, since the last 4 days, he needs 3 doses, SOS dose of morphine per day. So what shall we do now? Any guesses? Any suggestions? The patient was already on morphine, was having adequate pain relief, but since the last 4 days, he requires 3 rescue doses of morphine per day.
तो मैम 5 to 10 के बीच में डोज इसकी स्टार्ट करनी पड़ेगी क्योंकि ये पहले ले रहा है मॉर्फिन.
Anybody has any other suggestions?
Ma'am, if he comes for OPD, when we can give IV for initial treatment. Again, we can add up on 10 mg if he goes to home.
Okay.
मैम
So, right.
10% ऑफ हिज डोज जो 5 mg वो ले रहा है उसका 10% उसको एसओएस डोज दिया जाएगा.
Okay. So, thank you for all the responses. So, the patient was currently on 5 milligram Q4H, and we understand from the way he was making use of the rescue dose, we understand that he is not having adequate pain relief, and definitely we need to increase the dose. How much? So, usually when there is 2 to 3 rescue doses being used in a 24 hours period, we escalate the dose by 30 to 50%. So, when the patient is taking 2 or more than 2 rescue doses, in between, increase the dose by 30 to 50%. In every, sorry,
कौन सी
Deepak,
भैया नहीं है क्या?
sorry. So the patient can be, so the dosing of the patient can be somewhere between 7.5 to 10 milligram Q4H. So this patient will escalate the dose to 7.5 Q4H or 10 milligram Q4H. Hope I am clear.
Yes, ma'am.
Yes, ma'am.
Thank you. Thank you for that response. So now next question. How frequently would you give the SOS dose of oral morphine? I have been repeatedly telling you that we are providing with the SOS dose of morphine, SOS dose of morphine. So how frequently can we give this SOS dose of morphine? Any idea?
No, ma'am.
Okay. So,
एक्चुअली मैम जब तक पेशेंट को बेसिकली पेन में रिलीफ ना मिले तब तक.
but how frequently should we give this? Suppose
Approx
you give,
after,
yes, Dr. Devi.
हाँ जी मैम अप्रोक्स आफ्टर एवरी 10 to 15 minutes
10 to 15?
if patient does not get minute.
Okay, thank you for that response. So this brings us to the importance of knowing more about the pharmacokinetics of morphine. So morphine, it is an important opioid that is being extracted from the poppy plant known as Papaver somniferum. So legally, we have morphine cultivation occurring in Rajasthan, Uttar Pradesh, and Madhya Pradesh. So it is from the seeds of the poppy plant, we extract morphine. And so more about the pharmacokinetics, the absorption, distribution, metabolism, and excretion. So morphine is a weak base, and when taken orally, it is absorbed from the upper part of the small bowel. It is a hydrophilic, hence the onset of action is slow and it has longer duration of action. And when given through the sublingual route, it is absorbed very slowly, and the buccal and gingival absorption, the research shows very varied results for the buccal and gingival absorption rates, and it has got a bitter taste also. So now regarding the metabolism of morphine, once the morphine is swallowed, it reaches the gastrointestinal tract and it gets absorbed into the blood vessels and reaches the liver through the portal vein circulation. And in the liver, what happens? The morphine undergoes glucuronidation. That is, the metabolism of morphine occurs in the liver. And it gets converted into its active metabolites, which are then which reaches the systemic circulation. So, as I already told you, the metabolism of morphine mainly takes place in the liver, but a minor part of the metabolism occurs in the gastrointestinal tract as well as in the kidney. And what happens? The 90% of the morphine gets converted to its active metabolites. And the metabolites of morphine include morphine 3-glucuronide as well as morphine 6-glucuronide. So the morphine undergoes glucuronidation in the liver and gets converted to its metabolites, morphine 6-glucuronide and morphine 3-glucuronide. So this morphine 6-glucuronide is responsible for the analgesic effect of morphine. And this, due to this metabolism that takes place in the liver, so once it is taken orally, morphine takes around 45 to 1 hour to peak its action. So it undergoes metabolism in the liver and then the metabolites are being released into the systemic circulation. So the peak effect, the peak analgesic effect of morphine occurs in 45 minutes to 1 hour. And so can somebody tell me how frequently would you give the SOS dose of morphine when morphine is given orally?
45 minutes to 1 hour.
Yes. Thank you. Thank you, Sudhir, for that. It is 45 minutes to 1 hour. So once the oral morphine is given, it takes around 45 minutes to 1 hour to peak its action and gets the analgesic effect. So we'll wait for at least 1 hour, and if the pain relief is not adequate, then only we'll repeat the SOS dose again. So the SOS dose of morphine should be given at least in a gap of 1 hour, 45 minutes to 1 hour. I hope so. Actually, 15 minutes is possible. So 15 minutes duration, we repeat that is being 10 minutes, 10 to 15 minutes is being done in IV titration. So orally it takes around 45 minutes to 1 hour for the peak action. I hope it's clear.
Yes, ma'am.
Yeah, thank you. So next, moving on to another patient story, we have Mr. X, whose pain was stabilized with 10 milligram of oral morphine 4 hourly. But he finds it difficult to take it every 4 hourly. He says he is willing to take it if you give less frequently. What can we do about it? He is currently on 10 milligram of oral morphine every 4 hourly. But he says that it is very difficult to take the medication every 4 hourly. So what do we do for that? Do you have any suggestions?
We can go with the 15 mg 6 hourly.
Sorry?
15 mg 6 hourly.
15 mg 6 hourly. So when we go with 15 mg 6 hourly, but at a point of time, the analgesic dose in his blood would be increased. And he might come with toxic effects. Do we have any other options?
मैम उसे ओरली ना देके कोई दूसरा मीडियम लाइक पैचेस या जो रेगुलर अमाउंट में रेगुलर डोज उसको बॉडी में प्रोवाइड कराता रहे.
Okay. So, yeah, thank you for your responses. And now we have sustained release preparations available with morphine. So the patient was on 10 milligram of oral morphine 4 hourly. That means the patient was taking 60 milligram of morphine in 24 hours. So we can give this patient with sustained release of morphine. So the difference is that, so the regular or immediate release preparations, the duration of action is 4 hours. But with sustained release, the duration of action is 12 hours. So the patient who is taking milligram in 24 hours, you can give him with 30 milligram BD dose of sustained release preparation. I hope it's clear to you.
Yes, ma'am.
Okay, so this would be one of the choices, better choices. If you have a sustained release preparation, you can reduce the duration with the same effectiveness for patients with stable pain.
मैम इसकी जगह पे हम ट्रांसडर्मल पैचेस भी यूज कर सकते हैं, वो भी मतलब कई अप्रोक्स 2 to 3 डेज के लिए वर्किंग इफेक्टिव रहेगा, अगर कोई पेशेंट ओरल लेने में विलिंग नहीं है तो।
Do you have transdermal patches of morphine available?
मैम मॉर्फिन का तो नहीं पता, बुपिविकेन के नाम से जो बुपिनॉर्फिन आते हैं वो पैचेस अवेलेबल हैं।
You have buprenorphine?
It's...
Yeah, so that will bring us to the what are the preparations available, types of preparations of morphine that are available.
Okay.
So we have aqueous solutions of morphine available. We have immediate release tablets and controlled release tablets, and also we have injection morphine available. So we don't have patches of morphine available. We have other opioids. So in that situation, Dr. Divesh, we'll have to switch on to another opioid, and we'll have to start with the equianalgesic dose or equipotent dose of that opioid. So these are the preparations of morphine that is available. So now we have another patient story where Mr. X, who was on 10 milligram of morphine 4 hourly for the past 6 months, he was brought to you with excessive drowsiness. And on examination, it was found that he has a serum creatinine of 5 milligram per deciliter. Will you do anything with the morphine dosage? Any comments?
हम टाइटर करेंगे उसकी डोज।
Yeah. Why do you want to tighten the dose, Dr.
मैम
Lakshmi?
क्योंकि उसको ड्राउजीनेस हो रही है।
हाँ, so how will we tighten? How do we tighten?
We will decrease the dose, ma'am.
Yes, we will decrease the dose. But why? Why do you want to decrease?
Because मैम मॉर्फिन टॉक्सिसिटी हो रही है पेशेंट को इस वजह से।
Why is patient having morphine toxicity?
Overdoses of morphine or due to its not clearance from renal sites.
Yeah, so
Ma'am, 5 mg per dl creatinine means chronic renal failure.
Yes, Dr. Virender. So yes, so that brings us to that is the why how is morphine being excreted from the body. So morphine is excreted from the body by glomerular filtration, and so if they're in patients with renal failure or chronic renal issues, what happens is that the metabolite morphine 6-glucuronide gets accumulated, and as I already mentioned, the morphine is metabolized in the liver. It undergoes glucuronidation and it forms morphine 6-glucuronide and morphine 3-glucuronide. And if the morphine 6-glucuronide gets accumulated, what happens? The clearance is decreased. In the renal failure condition, the clearance is decreased, and the metabolite, the active metabolite or the analgesic medication remains in the blood for longer time. That is, the T-half is prolonged. So what do we do for this patient? We can either increase the spacing between the doses or we can reduce the dose. Make the dose thrice daily, or reduce the dose, or we can go in for alternate opioids. So these are the choices we have in this patient. Either increase the spacing, and so the patient was on the patient was on 10 milligram of oral morphine 4 hourly. Now we have reduce the frequency to thrice daily, 3 times a day. So the spacing between the doses is being increased. And the other option is you can reduce the dose or you can go for alternate opioids. So next we have another patient story. So we have Mr. X. He was sent home and he is now taking morphine. So he has got renal issues. So we have reduced the frequency of morphine to 5 milligram Q8H. But after 2 months, he was unable to swallow anything, including morphine, as he is terminal. What will you do for pain relief for this patient? How can we manage this patient at home? He is unable to swallow the oral morphine.
Ma'am, change to IV route.
So the patient wants to be in home.
Transdermal patches, ma'am.
So that is one option. So we can use the equipotent dose of another opioid, because as I already mentioned, we don't have a transdermal patch of morphine available. So we have another opioid, we'll have to switch to another opioid. That is an option. Suppose we don't have another choices with us. We don't have another opioid with us. What can we do? The only opioid available with us is morphine. And the patient wants to be taken care in the home itself. The patient doesn't want to come to the hospital. And he is unable to swallow. Do you think, is there any other option? Yeah, so we'll now learn about the routes of administering morphine. So morphine can be given orally, intravenously or subcutaneously, per rectally, epidural, and intrathecal. So anyone wants to comment on how we can manage that patient whom we just now discussed?
By per
Rectal,
rectal.
ma'am.
Yes, very good. So we can give the patient per rectal. So this patient 5 milligram per rectal 8 hourly. And the patient can continue his care at home itself. So we have the next patient story, that is about Mrs. K, a 55-year-old lady with carcinoma of colon. She has abdominal pain which is continuous in nature, and she is on 10 milligram of oral morphine Q4H and is not requiring any SOS dose of morphine, and it is a well-controlled pain. So now the doctor has asked them to replace the morphine with 25 microgram of fentanyl patch. The next day, the patient report to you telling that they replaced the fentanyl patch after 5 hours as she had no pain relief. What will you do? So here, the patient is having stable pain relief with oral morphine, 10 milligram Q4H. So the doctor has made an opioid switch to a transdermal patch, to fentanyl patch, 25 microgram. But after 4 hours, the patient was not having any pain relief, and so they replaced the patch. Any idea what will we do?
Then, ma'am, we give rescue dose of morphine and ask the patient to wait for some time.
Okay. But why do you think the patient is not having pain relief after 5 hours?
या तो मैम जो पैच लगा है वो जिसकी जो मेडिसिन है वो करेक्टली उसमें बॉडी में डिस्पेंस नहीं हो पा रही है उस मोड से, या फिर वो वीक उसके लिए वीक पड़ रही है, इफेक्टिव नहीं है उतनी जितना मॉर्फिन उसके लिए इफेक्टिव था.
Okay.
Ma'am,
Okay.
fentanyl patch works slowly, ma'am.
Work slowly. Okay. Any more responses? So now we learn a bit about fentanyl. So transdermal fentanyl patch. So this transdermal fentanyl patch, it is usually applied on an intact skin. So make sure that when you apply the transdermal fentanyl patch, you don't apply it on skin with hair or a skin that is being shaved with an eraser. Why? Why do you think that is inappropriate? Because it can create, sorry?
Absorption को रोकता है मैम.
Absorption. It interferes with the absorption. So there will be micro abrasions with the eraser. So it can cause, it will interfere with the absorption of the fentanyl. So always make sure that apply the fentanyl patch in an intact skin. And once the fentanyl patch is applied, what happens? It forms a subcutaneous depot of the drug. So a subcutaneous depot of the drug is formed and this is slowly released into the blood. And the effective analgesia occurs only after 8 to 12 hours. So once the patch is applied, it takes around 8 to 12 hours for the fentanyl to bring its analgesic effect. And as you have already mentioned, the patch lasts for 72 hours. So when we place a fentanyl patch, it usually lasts for 72 hours, that is 3 days. And as I already mentioned, the skin condition as well as the temperature can affect the absorption. And what kind of patients do we start with fentanyl patch? Only for patients with stable pain relief. So not suitable for patients with unstable pain, because once the patch is applied, we don't have any control over the release of the medicine. So only if the patient was having adequate pain relief or controlled pain relief with the already existing medication or the opioid, they can be switched to fentanyl. So fentanyl is usually given for patients with stable pain relief, and it usually lasts, the effect of fentanyl lasts for 72 hours, and its analgesic effect begins after 8 to 12 hours of patch application. And when I say 25 microgram of fentanyl patch, what does that mean? So we apply 25 microgram of fentanyl patch to a patient. That means that 25 microgram of fentanyl is released per hour into the body. And the patch can stay for 3 days. So the preparations of available of fentanyl which are available are injectable preparations are available, transdermal, oral transmucosal fentanyl citrate. And fentanyl is lipophilic in nature. It is 100 to 150 times more potent than morphine. And 25 microgram per hour of fentanyl patch is equivalent to 60 milligram of oral morphine in a day. So we saw that the patient whom we have started on fentanyl patch was taking 10 milligram of oral morphine Q4H. The 10 milligram of oral morphine Q4H means that the total dose in a day is 60 milligram. Then 60 milligram in 24 hours. So that patient we can switch to 25 microgram of fentanyl patch. And 25 microgram of fentanyl patch means that 25 microgram of fentanyl is being released in an hour. And this patch can stay for 72 hours. So this is another patient scenario where we have a 70-year-old man with carcinoma of lung with complaining of throbbing pain on the right front of the chest, which is a continuous pain with the severity of 5/10. He is a non-epileptic and he is on levetiracetam 500 milligram BD. How will you manage his pain? You can either unmute and respond or you can type in your chat box. How can we manage this patient's pain? He is having a pain with severity 5/10, a continuous type of pain, a throbbing pain in the right front of the chest.
By starting, ma'am, oral dose of 5 mg morphine QID per day.
Yeah. Okay. Any more answers? Why, Dr. Devish, you want to start with oral morphine?
Because ma'am, pain is moderate pain है, not severe है, mild to moderate pain है. Score आपने दिया जैसा कि 5 से 10 है, तो उसमें mild to moderate pain है. It can manage by 5 mg initial dose.
Yeah. So 5 to 10, that is mild to moderate pain. Which step of the WHO analgesic ladder do we prefer or do we go with? Opioids for mild to moderate pain?
Second.
Step 2. So what are the step 2 opioids?
Tramadol, morphine.
Sorry? Yes, tramadol is step 2, but morphine is?
Step 3.
Step 3. So what do you suggest for this patient?
Tramadol, ma'am.
In my opinion, ma'am, morphine.
Why, Dr. Devesh, you want to go with morphine? Why not tramadol? The patient has the severity is only 5/10. So step 2 of the ladder. So it is opioids for mild to moderate pain. Anybody agrees to Dr. Devesh?
Yes, ma'am.
Why, Dr. Sunita? Why you want to go with step 3?
मैम क्योंकि इसको एपिलेप्सी की भी प्रॉब्लम है, वो भी ध्यान में रखनी है.
Very good. Yes, Dr. Devesh, you are right. We are to go with step 3 in this patient because the step 2 opioids, which are commonly available in our setting as tramadol, tapentadol, they all reduce the seizure threshold. And we know that in this patient scenario, the patient is a non-epileptic already on anti-epileptic drugs. So the drugs that reduce the seizure threshold would be risky for this patient. So it is always preferable to start with a low dose of morphine, step 3 opioid. Thank you, Dr. Sunita and Dr. Devesh for that. It is step 3 opioid. Please keep this in mind because in patients with history of seizures or on anti-epileptics, be cautious in using tramadol. So now to learn more about the opioids. What are opioids? It's a general term which includes naturally occurring semi-synthetic and synthetic drugs which produce their effects by combining with the opioid receptors. And these are usually antagonized by the naloxone. So opioids are drugs which produce their effects by combining with the opioid receptors. So the opioid receptors include mu, kappa, and delta. Sigma is not a true opioid receptor because its action is not reversed by naloxone. Now, based on the receptor interaction, the opioids can be classified as agonist, antagonist, and agonist-antagonist. So what is an agonist? Agonist is that group of drug which acts on the receptor and increases its action. So, for example, morphine is a mu agonist. When we say morphine is a mu agonist, what happens is that this morphine, it acts on the mu receptors and produces the analgesic effect. So it sensitizes or stimulates the receptors and produces the analgesic effect. So what is an antagonist? Antagonist, they act on the receptors and bind to the receptors, but they opposes the action of the agonist. They will not allow the agonist drugs to bind with the receptor. So antagonists are those group that opposes the action of the agonist drug. How do they do that? By they themselves bind with the receptor. They bind with the receptor but do not produce any action and will not leave the receptor site for the agonist to act and produce its effect. So that is antagonist. For example, naloxone is an antagonist. So when we say naloxone is an antagonist, what happens is that when a patient on opioid is given naloxone, what happens? Naloxone binds to the receptor site and will not allow the morphine to bind to the receptor and produce its analgesic effect. That is how naloxone reverses the effect of morphine. So that is an antagonist. And we have another group of drugs called agonist-antagonist. When we say agonist-antagonist, these are drugs which have agonistic action at some receptors and antagonistic action at some receptors. So it could be the drug might have an agonistic action in the mu receptor. At the same time, it can produce an antagonistic action in the kappa receptor. So those group of drugs are called agonist-antagonist. So this is a classification of opioids based on their receptor interaction. Moving on to the side effects. So the adverse effects of morphine can be classified as side effects and the toxic effects. When we say side effects, these are the adverse effects that occurs with the therapeutic dose of morphine. What do you think is the most common side effect of opioids?
Then constipation.
Very good. Constipation is the most common side effect of opioids. Any other side effects of opioids that you would like to? Anybody? So when we started with the IV morphine titration, I said we should give which drug prior to the titration?
Metoclopramide. Metoclopramide.
Yes, exactly. Why? Because so one of the side effects of morphine is nausea and vomiting. So we need to provide an antiemetic prior to the morphine titration. Then the other side effects include sleepiness and tiredness, itching, dry mouth, urinary hesitancy. So the most common side effect with opioids is constipation. Around 95% of the patients develop constipation, and as long as the patient is on the opioid, this constipation will last. So whenever a patient is prescribed on opioid, make sure that a stimulant laxative is also being prescribed. So that is very important. When a patient is being started on an opioid, ensure that the patient is started with a stimulant laxative. It can either be bisacodyl or it can be sodium picosulfate. Any other stimulant laxative should be prescribed along with the opioid. And 1/3 of the patients, they develop vomiting and nausea. And vomiting and nausea is a self-limiting symptom. So in first 3 days, the symptom will get over. And this is basically due to the stimulation of the chemoreceptor trigger zone. So what do we do? So for the patients, when we start with the opioid, for the initial 2 to 3 days, we provide them with the antiemetic drugs that act on the chemoreceptor trigger zone. And those drugs include haloperidol, metoclopramide, or domperidone. So this is provided only for 2 to 3 days because the nausea and vomiting is a self-limiting symptom. The other symptom that occurs with the initiation of treatment in 1/3 of the patient is sleepiness and tiredness. So when you start a patient on morphine, to communicate to the patient that sleepiness and tiredness can occur, but it will get over in 2 to 3 days. But if it does not get over in 2 to 3 days, please let us know. So that should be informed to the patient when you start with the morphine. So now, what are the toxic effects of morphine? Anybody wants to talk about the toxic? What is toxic effect?
Unwanted effects.
Unwanted effects. Why does this toxic effect occur?
Due to overdoses of any opioids.
It could be because the dose is prescribed more than that is required.
Okay.
More than the therapeutic need. The dose is given in or the patient is given medication for not an opioid sensitive pain. Those two situations are where the toxic effects occur. When the administered dose is higher than that is required for pain relief, or when the pain has poor response. So that is when toxic effects occur. So what are the toxic effects of morphine? Delirium, myoclonus, drowsiness. These are the toxic effects of morphine. Any other toxic effects of morphine?
Ma'am, renal.
Kidney failure, ma'am.
Related to morphine. Due to morphine?
Ma'am, due to
Ma'am,
overdose.
respiratory depression.
Respiratory depression.
Because my morphine is centrally drug acting drug, it produces
bradycardia.
Yes.
Pinpoint pupil.
Yes. Pinpoint pupil. Yes, those are the toxic effects of morphine. Delirium. So, morphine does not cause renal failure. Patients with renal failure, if given morphine, there will be accumulation of morphine metabolites. And that is why this toxic effects occur. So, somebody said respiratory depression. So, does opioids produce respiratory depression?
Yes, ma'am.
How many of you are using morphine in your settings?
in current setting, ma'am, no one use.
No one
because
is
non
using.
availability of drug.
Okay, okay. Yeah, so what I want to tell you is, from my experience, I've been in palliative care since more than 10 years. And since this time, I have never seen a patient with respiratory depression due to morphine. This is because when patients take their medications by the mouth, and that is as per the principles of analgesic use, if you prescribe morphine to a patient, that is given orally by the clock and by the ladder, and if it is monitored cautiously, there is very, very rare chances of respiratory depression. So respiratory depression is very unusual. The important is that it should be monitored. And when you increase the dose of morphine, look in for the toxic effects, and with proper pain assessment, depending upon the pain, you titrate the dose. So when it is done like that, respiratory depression is very unlikely to occur. And respiratory compromises occurs in certain conditions. It may be due to some associated pneumonia, could be due to the pulmonary embolism or cardiomyopathy, or it could be due to some co-administration with some drugs. like benzodiazepines, they can produce respiratory compromise. Otherwise, if oral morphine is given cautiously and with the correct monitoring, respiratory depression is very unlikely to occur. Does opioids cause addiction?
Yes, ma'am.
Yes. So,
No, ma'am.
no. So what does the research say? So the research findings says that substance abuse as a result of medical use is very low. So, and there has always been a confusion between the physical dependence and psychological dependence or addiction. And the clinicians always overestimated the risk of addiction. That is what the literature says. So what do you mean by physical dependence? Or what is psychological dependence? Addiction or psychological dependence is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. There is impaired control over the drug use, compulsive use, or continued use despite harm and craving. So that is how the American Academy of Pain Medicine describes addiction or psychological dependence. And what is physical dependence? It is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. So that is physical dependence. How many of you drink tea in the morning? Or like, how many of you cannot stop drinking tea in the morning? Nobody drinks tea.
मैम ऐसा नहीं है, चाय तो पीते हैं बट ऐसा कोई एडिक्शन नहीं है सच.
Anybody else?
मैम पीते हैं और रोज जरूरत महसूस भी होती है मैम.
कैसे जरूरत महसूस होती? How do you feel that?
थकावट लगता है, यूं लगता है मैम जैसे एनर्जी नहीं है बॉडी में. चाय पीने के बाद एक जैसे एनर्जी आ जाती है काम करने के लिए.
Okay. Anybody else? So Sunita says that she
प्लेजर फीलिंग देता है.
Sorry,
प्लेजर फीलिंग देता है, इसलिए कई लोग पीते हैं मैम.
Sorry, Pratibha.
मैम प्लेजर फीलिंग, प्लेजर के लिए पीते हैं कई लोग.
Pleasure. Okay. Anybody else? So Dr. Sunita was telling that she feels loss of energy if tea is not taken. Anybody else have similar feeling? Yes, Dr. Madhu, you want to say something?
Yes, ma'am. Drinking.
Do you drink tea?
No, ma'am. Alcohol.
Sorry, we were talking about tea. So suppose one day Dr. Sunita feels that she doesn't have tea at home. So tea powder is not available at home, but she knows that it is available at her neighbor's house. But there is nobody at that house. So they stay in a flat. I don't know, Dr. Sunita, do you stay in a flat?
No, ma'am.
So, okay. So we are imagining that you're staying in a flat and you don't have a tea powder today, but your neighbor has got the tea powder. And you know that, but they are not there. You cannot ask them because they are not there. And what you do is that, so the morning, you really want to drink a tea. So what did you do? You broke open their kitchen, you got the tea powder and made the tea and drank. What is that?
Addiction, ma'am.
That is psychological dependence or addiction. So what is physical dependence? The physical dependence or the withdrawal syndrome is what Dr. Sunita was talking about. She feels loss of energy. She feels tired because the body has been used to having tea. Since a long time, the body has been used. And we have been giving the body this, but today suddenly we didn't. So the body itself is showing some withdrawal syndrome in the form of loss of energy, tiredness. That is physical dependence. This is just to understand the difference between physical dependence and psychological dependence in very simple words. I hope it makes sense.
Yes, ma'am.
Thank you. So now this is just a comparison of the cost of each opioids available with us. So 30 milligram of morphine in a day cost around 3 rupees 50 pice, and the equivalent dose of tramadol, that is 300 milligram, it cost around 24 to 50 rupees. And 12.5 microgram, which is the equivalent dose of fentanyl patch, cost around 250 to 400 rupees. And 5 milligram of methadone cost around 4 rupees 50 paise. This is just to make you understand that when you prescribe, just be aware about the cost and how the patient, how affordable the patient is, and channelize or streamline your prescriptions depending upon the patient's economic status also. So we have different options. So please keep this in mind when you do a prescription. Yeah. Thank you.
Thank you, Dr. Amrita. for
Thanks a
the
lot, ma'am.
wonderful presentation. Anybody have any doubts? Please ask.
Thank you, ma'am.
So we have around 68 participants. Please clarify your doubts if you have.
I hope was the lecture, either it was very clear or nobody understood anything out of the lecture. I'm not sure what happened.
नहीं मैम, बड़ा इंटरेक्टिव सेशन था, आपने बहुत अच्छा बताया मैम, थैंक यू.
Yeah, thank you, Dr. Lakshmi. So yeah, so Sudhir, we have a question in the chat box. How long can we continue with oral morphine? So morphine does not have a ceiling effect. So as I told you, in the titration of oral morphine, the only thing with which we titrate would be the pain and the toxic effects. How long the patient is having pain, which is responding to this opioid, you can continue that patient. But do monitor for the toxic effects. See if the patient is having opioid, if the patient is responding to this pain. I mean, the opioid.
Question in the chat.
Excuse me, one more question here. In a hepatic impairment patient, how much initial dose we must prescribe for as an analgesia?
Dr. Devish, can you please repeat the question?
In a hepatic impairment patient which have approximate bilirubin level is 5 to 7, then how much initial dose we have to prescribe that patient?
Dr. Devish, as we discussed the pharmacokinetics, so by now you might have understood that the metabolism of morphine takes place in the liver, and it is in the liver that the morphine gets converted to its metabolites.
Right.
And the active metabolites are mainly responsible for the analgesic effect than the prodrug.
Right, ma'am.
So we can prescribe morphine in the hepatic impairment, but the frequency should be reduced, or there should be spacing between the dosages.
Okay.
So we can start with 5 milligram, maybe 6 hourly, not regular as 4 hourly dose. We can do 6 hourly prescriptions, or we can, depending upon, mainly monitor on the toxicities, and if needed, you can reduce the dose to 8 hourly also, if any toxicity is set in.
Okay, ma'am. Thank you, ma'am.
Dr. Shivani, can you unmute and speak? Your question is not very clear. What exactly do you want to know?
Good evening, ma'am.
Yes.
Yes, ma'am. I just want to ask. A few days ago, a pregnant woman, come with 24 weeks of gestation, POG, and she had severe pain radiating to her leg, and we have given injection PCM, but no relief, and we are just giving her PCM tablet 6 hourly, and patient have very less relief, and she had a history of fall before pregnancy.
Yeah. And was that investigated, or?
Disc bulge was in MRI report.
So we don't recommend opioids in pregnancy. One option could be some interventions, especially in pregnancy. A choice would be some, if any pain interventions are possible, could be a choice. Other than that, the safer drug would be paracetamol itself.
Okay, thank you, ma'am.
Yeah.
Ma'am, tramadol is also contraindicated in pregnancy.
Yes. Tramadol is also contraindicated.
Ma'am, can we prescribe opioids to a lactating mother?
No, Dr. Devish.
Okay, ma'am.
Dr. Madhu is asking about any withdrawals effect. No.
Yeah. Dr. Madhu, can you unmute and talk a bit more about it? What do you mean by any withdrawal effects? Sorry, Dr. Madhu, you are not audible. Do we have any more questions?
No, ma'am.
No, ma'am.
So, can we wind up, ma'am? I hope this presentation is clear to everyone. They already clarified the doubts also. Can we find them?
Yes, yes, Shiba, I think we can.
Okay, yeah, so, thank you, Dr. Amrita, for the wonderful inviting session. I hope this session is fair to everyone. Thank you others for your contribution. Thank you all for participation. Thank you.
Yeah, thank you all for the active participation. Thank you, Shiba Madam, for the facilitation, but thank you, Amrita Madam, for the wonderful session. So I will be sharing a feedback form after this session. So please, you guys all need to fill that and submit. Thank you all.